All right. Good morning, everybody. Dr. Rafich here, Vet Triage. It is November 18th, Monday, 9:11 a.m. Pacific time. We are going through this issue of veterinary surgery. Um, this is the 20, what is this? May 2015 issue. And we're going to go through this paper. This is part 2 from yesterday's live stream, so feel free to tune into that one. Regenerating mandibular bone using RHBMP2, part 2, treatment of chronic defect non-union fractures. This comes out of the University in Davis, California. The objective is to describe a surgical technique using a regenerative approach and internal fixation for reconstruction of critical size bone defect non-union mandibular fractures. They had 6 dogs in the study. In 5 dogs, the repair was staged and extraction of teeth was performed. In a mean 27 days later, they used pharyngotomy intubation, so they intubated the patient through the pharyngeal region instead of intraorally like normal. And temporary maxillomandibular fixation was performed. So they occluded the jaw in the position they wanted, and then wired the jaw together temporarily so that they know that they had the right occlusion for these dogs, since they all had like malocclusion problems from chronic non-unions. Using an extraoral approach, a locking titanium mini plate was contoured and secured to the mandible. A compression resistance matrix, CRM, was infused with recombinant human BMP as bone morphogenic protein 2. It was implanted into the defect. The implant was then covered with a soft tissue envelope. Results: all dogs healed, immediate return to function, a correct occlusion. Hard tissue formation was observed clinically within 2 weeks, solid cortical bone in 3 months. They did a CAT scan in 1 dog by 3 months after surgery, and they found that the newly regenerated mandibular bone had 92% of the bone density and porosity compared to the contralateral side. Long-term was excellent. So, introduction. Individual mandibular fractures occasionally fail to heal, resulting in non-union, which is defined as a failure of the opposing fracture ends to unite and ossify. The amount of healing that occurs varies from fibrous tissue formation, cartilaginous bridge that does not mineralize, or absolute lack of bridging. According to the Weber-Czech classification, that's WEBR-CECH, a defect non-union occurs when a section of the bone is lost during a trauma because of sequestration or after surgery. The resulting gap between the remaining viable bone ends is too great to be bridged without surgical intervention. Common predispositions for non-union include comminution, infection, ischemia, hyperemia, excessive manipulation, hardware placement, periosteal stripping too early, or excessive mobility and imperfect reduction. Radiographic features include absence of callus, evidence of a fracture gap, sclerosis of fracture ends, and displacement. A common result of defect non-union fractures is malocclusion because of mandibular drift. Malocclusion may result in difficulty in eating and drinking, prehension and pain of the contralateral temporomandibular joint, or the TMJ. Autologous bone grafts and bone graft substitutes are examples of techniques used. However, these are still far from ideal because of donor site morbidity, especially in small dogs. Bone morphogenic proteins, also known as BMPs, are multifunctional growth factors within the transcription growth factor beta, TGF beta, superfamily that were identified by Urist, which is another study, based on their ability to initiate ectopic bone formation. Later, another study proposed that BMPs are responsible for the initiation of a cascade of developmental events in which progenitor cells are induced to differentiate into bone cells, thus resulting in new bone. Recombinant human BMPs, or RHBMPs, in spinal fusion, fracture healing, and engineering of dental tissues have been reported. Currently, RHBMP2 and RHBMP7, delivered via adsorption onto collagen matrices, are FDA approved for spinal fusion. So, materials and methods. All 6 dogs had marked malocclusion. In 2 dogs, the duration of non-union was known to be 2 and 5 years. Otherwise, the other dogs had unknown histories. They're all shelter dogs that had these traumas. In 5 dogs, the repair was staged during the initial procedure. Periodontal treatment was performed. And in 4 dogs, the teeth in or adjacent to the non-union fracture site was extracted. 1 dog was edentulous, which means lacking teeth. and the procedure was completed in a single session. The non-union site was debrided in all the dogs, which included removal of an intraosseous wire in one dog. And then they used the CRM, which we defined before as compression resistance matrix. It's made up of a collagen sponge with embedded granules of hydroxyapatite and tricalcium phosphate. Here are some cool images. In part A, you can see dental radiographs showing that obvious gap between the two bones. In B, you've got a CT reconstruction. And then you've got C, which is intraoperatively placing the composite and then the bone plate over it. And then you can see D and E showing healing of the fracture site based on three-dimensional reconstruction of CT or CAT scan or computed tomography. Dogs were intubated via pharyngostomy. The mandibles and maxillas were brought into desired closed mouth occlusion, and the mandibular and maxillary canine teeth wired together using 28-gauge wire. Using an extraoral approach, a single locking titanium 2mm 4 or 6-hole mini plate was adapted to the desired anatomic contour of the mandible in the ventrolateral position while avoiding tooth root damage. No tooth roots were damaged by the screws. The fracture edges were debrided to remove sclerotic bone and attach soft tissues using a hand piece designed for this, combined with an ostectomy burr or rongeurs. The plate was then secured to the bone with 2 or 3 locking titanium screws in each segment of the fracture. So this is the example above of a dog that had poorly done surgery. Somebody tried fixing it in picture B there. That's a radiograph, dental radiograph. And you see the wire between tooth roots. I mean, you don't really do it that way. But anyway, and then in part C, you can see the malocclusion, dog's teeth on the line, and then D shows the fracture gap after removal of the wire. Oh, and then at the bottom here, there's an example of a pharyngostomy tube. So the tube is placed into the side of the dog's neck there. Okay. The porosity and radiographic mineral bone density was measured for the native mandible and the mandibular repair tissue using free-form regions of interest that included the entire cross-section of the mandible, but excluded tooth roots or metal surgical implants. That's pretty cool. They were able to measure the bone density, and they are able to subtract from that the contribution from tooth roots and metal surgical implants. Okay, results. Mean age of dogs were 7.3 years, mean weight 4.8 kilograms. The non-union fractures were a mean length of 9.2 millimeters. Follow-up was a mean of 12 months. Clinical evaluation by 2 weeks after surgery, hard tissue spanning the entire defect site was palpable and covered by intact gingiva. One dog had a slight decrease in opacity of the implant material by 2 weeks. All dogs with recheck radiographs had increased opacity of the repair site, with smoothly marginated new bone formation bridging between the implant material and native mandible on radiographs by 4 weeks or later. And then here you can see this is the surgery itself. So A is right after surgery. B shows you the 4 weeks post-op, and then C is 8 weeks post-op. And you can see that the bone is remodeling. So pretty good. Okay. At 7 months, focal irregularities persisted at the dorsal margin of the mandibular repair, but the implant material was otherwise appeared remodeled and well integrated. CT images obtained in a single dog showed new bone formation and integration of the implant material with the native mandible at 3 and 4 months post-op. The porosity of the mandibular repair was similar to the native mandible at 3 and 14 months, so 26.8% and 27.4% porosity at 14 months for native and repair sites, respectively. The radiographic mineral density of the mandibular repair site was measured 0.9 times that of native at 3 months and measured 0.96 times density of native at 14 months. Pretty cool. All right, finally, discussion. Histologically, previous reports confirmed that CRM infused with RHBMP2 results in well-mineralized trabecular bone reflective of healthy bone turnover and remodeling. Several human case reports showed successful reconstruction of critical size mandibular defects by achieving this without the use of an autograft or other form of bone grafting. Successful spinal fusion and mandibular reconstruction in non-human primates, dogs, rabbits, because of robust formation of bone approximating native bone tissue was observed. The therapeutic outcome after use of RHBMP2 critically depends on the delivery vehicle, the quantity, the concentration, and time of application. Use of RHBMP2 without a carrier is contraindicated, and the selection of the matrix used for delivery must be carefully considered. In a rat critical bone defect model where RHBMP2 was used, the degree of bone formation was dose dependent. However, increasing it beyond a certain threshold does not improve bone quality and may promote lower quality and creating a detrimental inflammatory response. However, in cases where a higher dose of RHBMP2 was applied, there was an initial excessive bone formation, but this resolved after several months. Although it is accepted that with increasing age, number of stem cells decrease, the osteogenic capabilities of RHBMP2 are not negatively affected by increasing age. In agreement with this, they observed in this study excellent clinical outcomes suggesting that the presence and osteogenic ability of the resident stem cells in older dogs is sufficient. The procedure was staged to resolve infection related to periodontitis, remove teeth in the fracture line and affected by severe periodontitis, and remove previous failed implants and granulation tissue. To avoid subsequent surgery, we recommend that a single 2 millimeter titanium locking mini plate placed in the mid part of the mandible is used. This approach avoids iatrogenic damage to teeth roots, is sufficient to buttress the defect, does not result in plate failure, and avoids plate exposure through the mucosa. And that's it. Pretty cool study. I love this kind of stuff where they're using regenerative techniques. Obviously, it's a small number of dogs, but it's also not a common issue that we deal with. So thanks everybody who watches in the playback. We'll be back again tomorrow for another live stream. Take care.